Hello and welcome to our attendees here in the U.S. and around the world. Thank you for joining us for today's Nova Biomedical webinar, Clinical Significance of Ionized Magnesium in Critical Care. Our speaker today is Dr. Jessica Colon-Franco, Clinical Biochemistry Section Head and Medical Director of Special Chemistry in the Department of Laboratory Medicine at the Cleveland Clinic. We will also hear about hypomagnesemia and its association with several clinical conditions in critical care from Marcin Pasek, Nova's Senior Director of Medical and Scientific Affairs in Europe. I'm Rick Rollins, Director of Marketing here at Nova, and I'll be moderator for today's event. To take part in the discussion, you can post questions during the webinar using the Ask a Question tab on your webinar console. We'll address those questions following the main presentation and provide a full list of questions and answers soon after the webcast. This webinar has been approved for 1 contact hour of PACE continuing education credit and 1 CERP unit by the American Association of Critical Care Nurses. You can obtain your certificate by completing the post-webinar survey that will be sent following the conclusion of this webinar. If you fail to receive the survey, please be sure to check your junk mail folders in your email system. Also note that for on-demand viewing, credits are available for only 1 year after the initial airing of this webinar. You can register for future events on the NOVA website and explore our extensive library of on-demand content with topics ranging from clinical and veterinary diagnostic testing to biotech and pharmaceutical cell culture applications. Be sure to subscribe to receive notice of future NOVA educational webinars. You can also find more information about whole blood critical care testing products on the NOVA website. And now on to our main presentation. Dr. Jessica Colon-Franco is Section Head of Clinical Biochemistry and Director of the Special Chemistry Lab at Cleveland Clinic. She also serves on the adjunct faculty at Cleveland State University. In her current role, Jessica provides strategic, clinical, and scientific direction to the clinical laboratories in the section. She obtained her bachelor's degree in industrial biotechnology from the University of Puerto Rico and her doctorate in biochemistry and molecular biology from Mayo Graduate School, College of Medicine in Rochester, Minnesota, with additional fellowship training in clinical chemistry at Vanderbilt University Medical Center. Jessica is a diplomat of the American Board of Clinical Chemistry, a fellow on the AACC Academy, and is a member of several laboratory medicine associations, where she has served in various committee roles. Among these, the Latin American Working Group of ADLM's Global Quality Initiative. Jessica's interests are focused on endocrinology, therapeutic drug monitoring, and toxicology, and inflammatory biomarkers. Please welcome Dr. Jessica Colon-Franco.
Thank you, Rick, for the introduction and for having me today to discuss this topic. I'm very excited to talk to all of you about the importance of measuring ionized magnesium, particularly in critically ill populations. My name is Jessica Colon-Franco, and I work at the Cleveland Clinic Laboratory at Main Campus, where I am medical director of both Special Chemistry Laboratory and also our acute laboratory, where we measure blood gases as well as ionized magnesium for our critical and intraoperative patients. Today, I'm going to be discussing with you the measurement and clinical significance of ionized magnesium in critical care. After we're done with this activity, participants will be able to explain the importance of ionized magnesium in critical care. We'll be able to differentiate between total serum magnesium and ionized magnesium and describe the methods that are used for accurate measurement of particularly ionized magnesium, and we'll discuss when it's appropriate to measure ionized magnesium in critical populations and identify patients with certain conditions that warrant testing by ionized magnesium. Let's start by talking about magnesium, sometimes referred to as the ignored or forgotten ion. However, it's the 4th most abundant cation in the body, the 2nd most abundant intracellular cation, just after potassium. In terms of where we can find potassium in the body, just like calcium, most of it is in the bone. The majority of magnesium is intracellular, and some of it is also in the tissue and muscle. Only 1% of magnesium is found extracellularly, where it can found either bound to proteins, mostly albumin, complex to anions like oxalate or phosphate, or free, also known as ionized, which is the physiologically active portion of magnesium, which will comprise most of the extracellular portion of magnesium in the extracellular compartments. Of note, interestingly, is that the concentration of magnesium in red blood cells or within erythrocytes is much higher than of plasma, about 3 times higher. Magnesium has a variety of important roles in the body, including its participation as a cofactor in over 300 enzymatic reactions, most of which are very important either for generation of energy, such as ATP-related reactions, and also reactions that are directly related to the synthesis of DNA and proteins. Magnesium has an important role regulating the concentration of intracellular calcium, and it does so in different ways. For example, it competes with calcium for membrane binding sites, and this has a direct effect in muscular contractility and the activity of the electrical activity of myocardial cells. Magnesium is also a key player in modulating ion transport pumps and channels, which are going to affect the cellular balance of potassium and calcium in the body. Magnesium also affects and directly influences potassium, sodium ATPase pumps, which are going to regulate the amount of ATP or energy that is inside a cell. Fortunately, magnesium is widely distributed in foods. Green vegetables are particularly rich in magnesium because it's a component of chlorophyll, and the recommendation daily intake varies slightly between men and women, being a little bit higher, 420 milligrams in men versus 320 milligrams in women. Magnesium homeostasis is not regulated through hormonal regulation, but there are 3 main mechanisms that preserve the homeostasis of magnesium. These include urinary excretion and reabsorption at the kidney, release from bone storage, and intestinal absorption. Absorption in the gut is directly controlled by how much the body needs, the body requirements, and the amount of magnesium in plasma. But in reality, the main organ responsible for homeostasis is the kidney. Those patients that would experience kidney disease may suffer hypomagnesemia, and we're going to see the importance of ionized magnesium measurement, particularly in patients with kidney disease. When this balance or this homeostasis is altered, this can lead to either deficiency or excess of magnesium. Deficiency is really the most common observed clinically, and there's a long list of conditions or situations that will cause deficiency. These include malabsorption, redistribution, certain drugs. So this list is really a small list compared to all the causes of hypomagnesemia. The most common cause of magnesium loss is a loss associated or combined with other cations. For example, gut loss from diarrhea, or loss through the kidneys or inability to reabsorb it, which could be drug-induced or related to a chronic or acute condition. The prevalence of hypomagnesemia, which I told you is the most common, really varies across studies. Is mostly demonstrated by the measurement of total magnesium, not ionized magnesium, and depending on the study, the clinical scenarios, the patient population is being reported from approximately 10% to 60%. Excess is not as common, but is frequent and reported in patients with renal failure. Excess due to high intake, it's going to be uncommon if patients have renal function, because as we talked before, the regulation of magnesium in the body is mostly mediated through the kidneys. So how do we assess if there's a normal, low, or elevated concentration of magnesium in the body? The most common method used clinically is measuring plasma or serum total magnesium concentrations. And this is going to be relevant in many clinical situations. It's a practical and easier way to determine magnesium, but it may not reflect total body status and may not be applicable in clinical situations such as patients that are critically ill. There are less common approaches to determining the concentration of magnesium, which are reported or regarded as more valuable clinically. One of them is the measurement of plasma, serum, or whole blood ionized magnesium, magnesium inside red blood cells, or a parenteral loading test, which is considered the gold standard, but definitely not an ideal method to evaluate to assess magnesium status in patients. So let's get into how we measure magnesium. The total measurement, commonly done in serum or plasma, is often done by using a colorimetric assay, or some vendors also have an enzymatic assay. This is commonly performed in a central laboratory, and it has some utility, particularly in patients that don't have acute illness or other comorbidities that may affect the concentration of total magnesium and the balance between total magnesium and ionized magnesium in the body. Second, it's the measurement of ionized magnesium. In our laboratory, we perform this testing by whole blood, although plasma and serum are also available. The method includes ISEs, or ion selective electrodes, and this is regarded as a highly clinically relevant measurement, particularly in critically ill patients. Last but not least, there's also laboratories that perform measurement of magnesium in red blood cells. Our laboratory also performs this testing using inductively coupled mass spectrometry, or ICP-MS. And this is going to be helpful to assess magnesium status in the tissue or the body. It's a high complexity test. It's a laboratory developed test with high pre-analytical requirements, such as the separation of red blood cells before the samples arrive to the laboratory for assessment. And in this graph, I show you how proportionally different the amount of testing that we do for each one of these tests is. So we do a difference of about 5 to 6-fold less red blood cell magnesium than ionized magnesium, and about 20-fold the amount of total magnesium versus the amount of ionized magnesium. And this is in part because the measurement of ionized magnesium is still mostly limited to the availability of devices that can measure and assess directly ionized calcium in samples, which could be at the point of care or in analyzers such as blood gas analyzers, such as the ones that we have in our laboratory. Why do we measure ionized magnesium in our acute blood gas laboratory? Well, there's a long body of evidence, and it's well documented that the concentrations of total magnesium do not correlate well with the concentrations of ionized magnesium, which is the active form of magnesium in the body. And this is particularly affecting patients that have either an acute condition, an alteration in serum protein concentration, such as albumin, pH changes or acid-base disturbances that are going to alter the binding of magnesium to some of the other binding proteins or molecules, and also medications that either affect or directly impact the absorption of magnesium, or maybe nephrotoxic, for example, and also affect the absorption of magnesium. Some of the data that exists about this poor agreement between ionized magnesium and total magnesium describe low correlation coefficients, or even some of them say the correlation coefficients are good or acceptable. However, consistently it's reported that there's low categorical agreements between total magnesium and ionized magnesium. For example, there's publications that patients with low or hypomagnesemia using total magnesium measurements do have a normal ionized magnesium result. Or, for example, in pediatrics patients, it's also being reported that patients with a normal total magnesium have really low ionized magnesium values. And when this is all accounted for, this is going to impact patient management, cause delay management as needed, cause unnecessary repeat testing or unnecessary magnesium supplementation. So can total magnesium predict ionized hypomagnesemia? The answer is no. As we talked before, discussed in the previous slide, the correlation is poor. But just to give you some more data about this, it's been shown that about 50% of critically ill patients in a study that had low total magnesium had really a normal ionized magnesium. The majority of them, 70% of them. Thus, the predictive value for a low total magnesium, for a low ionized magnesium, which is the clinically and actively relevant in the body, it's only 30%, with a sensitivity of 75%, but a very low specificity of 40%. So it's been established that we need to rely on accurate ionized magnesium measurement by measuring it directly, not by drawing a conclusion based on the total magnesium concentration, or even calculations from albumin and total magnesium are considered unreliable. I'm going to talk briefly about a case that highlights some of the important aspects of measuring ionized magnesium, particularly in populations that are critically ill. In this case, this is a patient with end-stage renal disease and also hyperparathyroidism. It's a 55-year-old male that presented for surgery, for a parodectomy surgery. The patient has a past medical history of interstitial lung disease, end-stage renal disease after having a transplant, and hyperparathyroidism. The patient is on immunosuppressants, tacrolimus, and diuretic drugs. Here we can see some of the laboratory values that the patient had before going to surgery in the pre-op column. You can see that consistent with the kidney disease of the patient, creatinine is elevated. Calcium was controlled at the time. Other values were also normal, including phosphorus, albumin, and magnesium. And you can also see the post-operative results where calcium is slightly elevated, as well as ionized calcium. Phosphorus is decreased, but albumin and magnesium remain normal. However, because this patient was being managed by the anesthesia team intraoperatively, there were ionized magnesium measurements taken on this patient or ordered for this patient. And as you can see, in between the pre-op and the post-op results, where magnesium, total magnesium, was within the normal reference range, the patient's ionized magnesium was low, well below the reference interval of 0.45 to 0.6. And this patient was managed with IV magnesium sulfate as a result of this ionized magnesium results. Once again, highlighting that even in patients with a normal albumin concentration, the total magnesium values may be misleading and misguided, and the ionized magnesium values are more reliable in patient populations such as these, with a clinical history of a patient with kidney disease and medications that directly affect calcium, that directly affect magnesium reabsorption, such as tacrolimus and diuretics. There's many ways in which magnesium is affected in kidney disease. In chronic kidney disease, the first association of a magnesium dysregulation is hypermagnesemia, particularly at late stages, stages 4 and 5. However, in end-stage renal disease, there's an observation of hypomagnesemia, and this is directly correlated with a higher mortality outcome in groups of patients that have low magnesium. Dialysis patients, depending on the type of dialysis that they're receiving and supplementations and so on, comorbidities and whatnot, may be hypo or hypermagnesemic. And patients with a transplant, particularly those that are in immunosuppressants like calcineurin inhibitors that affect the reabsorption, that directly affect the reabsorption of magnesium by the kidney, hypomagnesemia is highly prevalent in these patients. And these patients also have many other comorbidities or in other medications that directly influence magnesium concentrations. This is of particular interest in patients that have received a kidney transplant because it's been reported that hypomagnesemia worsens patient outcomes. Particularly, hypomagnesemia affects cardiovascular risk by causing atherosclerosis, as well as affecting other metabolic conditions leading to diabetes and so on, which have a direct effect in increasing the cardiovascular risk of these patients, which may increase the risk of graft rejection or graft function decline, as well as cardiovascular events. This article highlights this phenomenon or this finding and the effect of using different tests for ionized magnesium or for total magnesium, particularly in a pediatric patient population. In this study, there were both a retrospective cohort that was monitored for magnesium concentrations using total magnesium and a prospective smaller cohort. In the retrospective cohort, they found that almost most of the patients develop hypomagnesemia within 28 days after transplant. Interestingly, in the patients that they evaluated prospectively, about 40% of them had low total magnesium, but of those, only 50% really had low magnesium. About 50% of them had a normal ionized magnesium. Also, about 25% of the isolated low ionized magnesium had normal total magnesium, suggesting that low total magnesium could not reliably predict if the patient had a low ionized magnesium, and patients with a normal total magnesium could have had a low isolated ionized magnesium. So they concluded that ionized magnesium cannot be reliably predicted either from total magnesium or ionized magnesium either, which has been proposed as a surrogate indicator of the status of ionized magnesium in patients. Very similarly, in this study of 104 adult patients after kidney transplant, the proportion of patients with hypomagnesemia, if you test for ionized magnesium, was about 50%, and if you test for total magnesium, the proportion was about 28%. Once again, cementing the fact that there's very poor correlation and concordance in the classification of magnesium status in critically ill patients and also in patients after kidney transplant. And in this case, about 25% of the patients also had miscategorical agreement, in which 25% of patients with low ionized magnesium had a normal total magnesium. So what are the implications of this unreliable magnesium assessment if we only rely on total magnesium to assess these patients? Well, hypomagnesemia may go untreated and undetected, which is being shown to result in poor outcomes and increased mortality in patients after kidney disease and also in critically ill patients. Or it can lead to the over-administration of magnesium supplements, which is may seem benign, but is not without effects. One commonly reported effect is that it would increase diarrhea, and that would directly affect the absorption of immunosuppressants and can lead to unnecessary and recurrent dose adjustments in these patients. To conclude our discussion today, we've shown that hypomagnesemia is associated with higher mortality and poor outcomes. We've also discussed that ionized magnesium is the active form of magnesium that is going to be independent of alterations in binding proteins and pH, and that you cannot reliably use either calculations or total magnesium concentrations measured in the central laboratory to reliably predict ionized magnesium concentrations. And that is important to measure ionized magnesium in patients with suspected hypomagnesemia, particularly populations that are at high risk of having low magnesium. And this includes both critically ill patients, patients after kidney transplant, and patients with other comorbidities that may affect the reliability of that homeostasis and balance between total and ionized magnesium. Thank you for your attention. I'm going to pass it back to Rick to continue with the program.
Thank you, Dr. Colin-Franco. Those are some great insights in ionized magnesium research. Next, Marcin Pasek will discuss the advantages of using ionized magnesium as an indicator of hypomagnesemia in critically ill patients. Marcin?
Okay, thank you, Rick, for the kind words and introduction. So here's our presentation for today. The topic is the clinical relevance of ionized magnesium for critically ill patients. My name is Marcin Pasek, and I'm Senior Director for Medical and Scientific Affairs at Nova Biomedical. So here is very briefly our agenda for today. First, we'll talk about magnesium, the metabolism and the physiology. Then we'll ask a question, is there any difference between total magnesium and ionized magnesium? We'll look on some clinical cases, and we wrap it up with a brief summary. All right, so I would like to start with taking a quick look on the cellular importance of magnesium. It is very interesting and important, and you will see in a second why. So magnesium is transported at the cellular level by several different molecules, among them TRPM-T7, magnesium receptor, one of the most important ones involved in the magnesium influx in a cell. And it is very important to remember that magnesium is involved in multiple inside the cell processes, such as protein, carbohydrate, and lipid metabolism, membrane permeability, ion flux, and neuronal conductivity. And just by the simple introduction on the cellular level, it is already very clear that magnesium is important and involved in multiple reactions with other electrolytes and their influx in the cell, and not only that, but also neuronal conductivity. So let's look on magnesium in maintaining health. It's, as I said, a very important ion, the second most abundant intracellular cation. It is involved in the regulation of other cations such as potassium, sodium, and calcium. And as I said before on the previous slide, it is the cellular activity of magnesium that is important, and it's you will see it in many different processes. And for overview intensivists, you might see sometimes a problem with hyperkalemia. And you will know that hypokalemia might be related with hypomagnesemia, which is sometimes difficult to detect. And this is the interplay on a cellular level between magnesium and other electrolytes. Of course, as I mentioned before, it is involved in skeletal and cardiac contractility, platelet coagulation, blood pressure regulation, and regulation of glycemia and insulin levels. It is involved in over 350 enzymes regulation. So magnesium is one of the most important electrolytes you might find in your body. Now, is there any difference between total magnesium and ionized magnesium when we look at them on a clinical picture? Now, I would like to start with this publication. It's not very recent one, but quite nicely captured the differences between magnesium levels. It's 2007. And here you can see on the x-axis, we have free ionized magnesium concentration, and on the y-axis, we have a total magnesium concentration. And if you look closely on this, we have a significant pool of patients that are in the normal range if you look on total magnesium, here as you can see in this yellow, but they are in fact hypomagnesemic patients if you look on ionized magnesium range, okay? And vice versa, if we look on the other spectrum of this graph, you will see that we have a group of patients that are normal on total magnesium, but are in fact hypermagnesemic when you look on ionized magnesium. And these are important differences related to the treatment of the patients. Now, this is a few years later, 2017. Very interesting paper, critically ill patients in a severe burn department in the hospital. So this is quite complex graph. I will walk you through in the next slide, but as you can see, again, we have ionized magnesium on the y-axis and we have total magnesium on the x-axis. As you can see, we have some of the measurements in patients that are in quite good correlation and agreement between ionized and total. But then we have a whole set of patients that do not agree in the measurements between total and ionized magnesium. And they are captured here in this table. As you can see, we have quite a significant number in patients that are hypomagnesemic by total magnesium level, but in fact, they are normal magnesemic by ionized magnesium. And if you look on another group of patients, those 72 patients are normal magnesemic if we measure the total magnesium, but in fact, they are hypermagnesemic if we look on ionized magnesium. And vice versa, we have another group of patients that are normal magnesemic by total magnesium, but in fact, they are hypomagnesemic if we look on ionized magnesium. So we will see that there are many discrepancies, both on the hypo and hyper magnesemia levels. Now, that was done in the one of the clinic in the United States. So the authors look on a quite simple approach to look on the savings. They just calculated the savings they can done in 3 months by not doing unnecessary magnesium tests and not giving the patients magnesium sulfate, those patients that were either normal magnesemic by ionized magnesium or even hypermagnesemic. So that's a simple savings, but they don't look on other savings such as prolonged stay in an ICU, etc., okay? But still very insightful paper from 2017. Now, let's look on our magnesium distribution if we would like to measure magnesium. So this is a magnesium distribution in the adult. We have roughly half in the bones, 25 to 30% in the muscle, and the rest about 20% in the soft tissue. And we have erythrocyte fraction and we have a plasma fraction. Now, as you know, the plasma fraction, the whole blood fraction, is something that we can measure on the point of care analyzers. And if we look on the plasma fraction, so this is in fact what we are measuring. We have a part of ionized, which is 55 to 70%. And this is the ionized magnesium that we referred to in the previous work that I showed. And this is the fraction we want to measure because this is the biologically active fraction. And then we have a complex anywhere from 5 to 15%. And then we have protein bound anywhere from 20 to 30% of a total magnesium. So if we measure in the whole blood the total magnesium, we do not distinguish between all those fractions. So if we want to know the active fraction, the biologically active fraction, we would have to measure the ionized only. And again, this is the problem you will be facing in your clinical practice if you ask for a total magnesium in a central lab versus ionized magnesium on the ionized magnesium capable analyzer. So as I said, if you measure total magnesium, it fails to distinguish the three important forms of serum magnesium. And we already know that only the ionized magnesium is the physiologically active fraction. Now, to make it a little bit more difficult for everyone, I did pull out here some reference ranges, both for total magnesium and ionized magnesium. Now, these are from different publications. As you can see, for ionized magnesium, the ranges go from anywhere from 0.45 up to maybe 0.67 millimole per liter. And here I put together the ranges from the newest publication in EJN journal 2025. And here the authors look on ionized magnesium ranges for normal, healthy patients, and they establish it from 0.4 to 0.68. They look on cardiovascular patients, and as you can see, the ranges starts with slightly lower cutoff, 0.38. They look for hypertension patient as well, and it starts even lower. The range is from 0.33. And then on diabetes mellitus type 2 and CKD patients. So as you can see, the ranges are different. They start with somewhat different cutoffs on the low end, and they also go to slightly different cutoff on the higher end, especially for diabetes patients. They go up to 1.04, whereas in the different cases, you will see it up to maximum 0.76. Or as in the previous publication, around 0.6. So that's interesting. And of course, it depends on many different factors, both physiological as well as geographical. Depends on the food intake of your magnesium and the water content of magnesium and other ions that you're exposed to during your whole life. So there are many papers that start the clinical work by looking on the ranges for a local geographical variation. And this is a very interesting and an important thing to remember, that there are significant variation in ionized magnesium concentration without corresponding change in the total magnesium, okay? And why? There are changes in pH and changes in acid-base status that are influence the ionized magnesium concentration, but will not be reflected in the total magnesium. But as we're talking about critical care patients today, I would like to point your attention to the last part of this slide. We have significant differences between ionized magnesium concentration that are not reflected in the total magnesium in the increased presence of anionic ligands, especially in the presence of citrate and bicarbonate, and of course lactate as well. But citrate is the one that we will see very, very often in the critical care setup. And as you remember, and we will talk about it in a second, citrate will bind in a non-specific way to any bivalent ion. And of course, hence, since several decades, in fact, we are measuring ionized calcium as a standard of care for many different pathophysiologists in the patients at ICU. But in the same way, we are not measuring as a standard of care ionized form of magnesium. And clearly we should, because citrate, because it's a non-specific agent, will bind to calcium exactly in the same way as it will bind to magnesium. Hence, if in those group of patients, we will look on the concentration of total calcium or total magnesium, of course, it is there, but it is not available for the patients and for the metabolism because it's bound to citrate. Now, only the ionized form, both of calcium and magnesium, is available for the metabolism and any reaction within the body of the patient. So this is, of course, the form we should be measuring. Now, let's take a quick look on several clinical cases. I'd like to start with this paper, and it's very interesting, even though it's very old. It's been published in 1993. And it shows you, first of all, very interesting outlook on the fact that more than 30 years ago, ionized magnesium was available for measuring in clinical practice, but somehow it still did not penetrate to the standard of care approach in the hospitals around the world. And also shows you that the authors were interested in the differences between total and ionized magnesium more than 3 decades ago. Now, as you can see here, we have magnesium in cardiology and in patients undergoing cardiopulmonary bypass. As you can see, before the procedure, the concentration of ionized and total magnesium is very similar, as you can see here on the graph. 1 hour after, there's practically no difference. There are very slight difference between them, but they practically behave the same. Now, what is very interesting, you will see a dramatic decrease in ionized magnesium 24 hours after the operation, and you'll see the patients are now in a deep hypomagnesemia, whereas when we look on the total magnesium concentration, it practically remains the same with even a slight increase. Now, this is very interesting observation. As you can see, it is not true if we look on the calcium in those patients. They behave completely similar. The effect is only seen on ionized magnesium. And the authors concluded that the fall of ionized magnesium after CPB for some hours may be implicated in a high incidence of arrhythmias. Of course, in the cardiopulmonary bypass, after 24 hours, there's a significant percentage of patients suffering from arrhythmias, and the clearly visible hypomagnesemia on ionized magnesium might be one of the reasons why this is happening. Now, I would like to jump forward. This is 2018, so much closer to today. And this is very interesting paper when the authors look on the protein pump inhibitors and serum magnesium levels in the patients with torsade points. So here's our ECG with prolonged QT intervals. And then we have a serum magnesium concentration for torsade points versus control. As you can see, in general, in torsade points patients, we have a lower concentration of magnesium. But if you look on torsade points and patients taking protein pump inhibitors, we'll see that those patients in majority are in deep hypomagnesemia. Interesting and curiously enough, we don't see this same effect when the authors look on serum potassium, serum calcium, and serum sodium. So there is no impact on PPIs on either sodium, calcium, or potassium. The effect is specific for magnesium, and you can see it very clearly on this publication. And last but not last, very interesting paper that's even newer, that's 2021. 92 patients, 185 samples, so multiple measurements per patients, continuous venous hemofiltration, patients with citrate being used as an anticoagulant. Now, if you remember what I said just a few slides ago, for all those patients in ICU where citrate was used, we do expect a difference between total and ionized values for both calcium and magnesium. And this is exactly what we see on this graph here. So you have patients, CVVH patients here in the red, and the rest clearly here. And you have the differences on between ionized magnesium on y-axis and the total magnesium in the x-axis. And here, importantly, the authors stated that, in conclusion, ionized magnesium and not total magnesium was identified as a discriminating marker for hypomagnesemia in citrate unrelated CVH patients. There is clearly a clinically added value for measuring ionized magnesium over total magnesium in this population in exactly the same way as we as a standard measuring ionized calcium in this population of the patients. Therefore, ionized magnesium and not total magnesium should be measured in these patients to determine the requirement for magnesium supplementation. And this is, of course, what we were expecting to see when we have patients that are anticoagulated with citrate. And this is the last publication I would like to point your attention to. This is the newest we have about ionized magnesium, published in last year, 2024. This is a study about monitoring total and ionized magnesium in children undergoing liver transplantation. And the aim of the study was to look on correlation and agreement between ionized and total magnesium and the relationship between magnesium levels and clinical events in the pediatric patients undergoing liver transplant. This study was done with 42 pediatric patients undergoing liver, multivessel, or liver kidney transplantation. So here are the data. As you can see, we have, this is of course summary of all the patients and all the data. We have both magnesium and calcium graph for ionized version of the electrolyte and the total. As you can clearly see, the correlation between ionized and total is very poor, both for magnesium and calcium. And here are the summary of the data for this study. As you can see here, the measurements were done during different phases of the operation of the transplant. As you can see, if we look on the dissection phase, there was roughly 48% of the patients that were hypomagnesiemic versus 26% looking on the total magnesium. And if we look on the anaphytic phase, the difference is even more striking. We have 60% of the patients with ionized hypomagnesemia versus only 2% of hypomagnesemia if we look on total magnesium values. And in summary, the authors concluded that there was a weak correlation between ionized and total magnesium levels. The ionized magnesium concentration progressively decreased during the dissection and anaphytic phase, whereas the total magnesium concentration show up an upward trends. The incidence of hypomagnesemia was 76% for the ionized magnesium for total patients, compared to only 22 if we look on total magnesium. And as a conclusion, the author stated that total magnesium does not reflect the important changes that occur during liver transplantation. These results show the significance of the use of ionized magnesium in the pediatric liver transplantation, although, of course, more clinical work is needed. And to summarize today's webinar, magnesium abnormalities are widely prevalent in clinically ill patients. They present severe clinical manifestations associated with increased morbidity and mortality. It is important to monitor patients on admission and during follow-up to determine magnesium levels in critically ill patients, particularly those with recognized comorbidities and risk factors. And inclusion of a point-of-care ionized magnesium testing in the intensive care protocols will allow more accurate diagnosis and more effective treatment of dysmagnesiemias in critically ill patients for both hypo and hypermagnesemia, of course. And serial monitoring during hypomagnesemia correction therapy will reduce the risk of hypermagnesemia, and vice versa, continuous monitoring at the end of therapy will prevent the recurrence of hypomagnesemia. And that's it for today. Thank you very much for your attention and for spending the time with us. And I will turn out to Rick now for questions. Thank you.
Thank you, Marcin. Now, before we begin the question and answer session, just a reminder to submit questions for Dr. Colanfranco and Dr. Pacek using the Q&A tab on your webinar screen. Also remember that your continuing education certificates will be emailed once you complete the post-webinar survey. A link will be provided to you at the conclusion of the webinar. Now we'll take a few questions from our audience. This first question for Dr. Colanfranco. Is there a concern that prophylactic treatment with magnesium in transplant patients may lead to hypermagnesemia?
That's an interesting question. I think there's a lot of focus in the effect of hypomagnesemia in this patient population and the effects of hypomagnesemia. But like I said before, the overtreatment with magnesium is not without consequences and costs for these patients. I don't know, it's been widely studied what the effects are, particularly of overtreatment of magnesium in patients with kidney transplant, but it's something that definitely warrants attention and requires better understanding of the potential consequences of overtreatment.
So thank you. I understand that. Another question, is hypermagnesemia less of a concern than hypomagnesemia in these cases?
That is also a good question. And there's still a lot of unanswered questions in terms of how to monitor magnesium and magnesium treatment and therapy, particularly in patients that are monitored longitudinally, such as patients after transplant. And the reality is that tests such as ionized magnesium are rarely available to those patients once they hit the outpatient setting and are not available for monitoring with ionized magnesium. So I don't know about more or more frequent testing, but I think that definitely we should be exploring what is the correct test to monitor ionized magnesium and hypomagnesemia in patients after a transplant, whether total magnesium meets that need, or we need to find alternatives to be able to offer ionized magnesium more readily to that patient population.
Okay, we have another question for Dr. Colin-Franco. Some studies have shown agreement between ionized magnesium and total magnesium, and others, including the studies that you have referred to in your presentation, show some disagreement. Do you think this variation could be due to the severity of illness?
That's definitely something that I observe too when I review the literature, is that some articles report good correlation, but even articles that report a good correlation may have a low percent of categorical agreement, or a category of patients that are still misclassified depending on the total or ionized magnesium measurement. And in terms of the heterogeneity of the studies, that's definitely something that is contributing to these differences. Different patient populations with different comorbidities, and there's a lot of factors that can affect the concentration of magnesium in the body, including medications and so on. So without having the ability to take all these into account, those confounding factors would still exist in the literature. Also, there's a lack of multi-center trials and some more sophisticated evaluations of these type of questions in the literature.
So we'll conclude the webinar at this point, but I want to thank the audience for those excellent questions and also thank our speakers. Be sure to join us again and invite your colleagues to attend the next Nova Biomedical educational webinar. You can register at novabiomedical.com/webinars, where you will also find a full catalog of on-demand webinar offerings. So for Dr. Colin-Franco and Dr. Paycheck, I want to thank you for your attendance and wish you a great rest of the day.